Welcome everybody. I don't even need to say it, the machine does it for me. Can I welcome everybody, and particularly Lambros, because we had a little discussion. Lambros Bourantas, who is a consultant hematologist at our incredible Imperial College Medical Institution here in London. I could say lots of things about him, but it'll come clear. He is of Greek origin. I've learned today married to a Ukrainian, but working here in London. He has taught, he has practiced, and he is trying to extend the whole of the area of concern that we're discussing today. And the reason that we are so keen to have Lambros Bourantas with us is that if you look at any developing country, these are the sorts of diseases that they're not yet coping with. And therefore, I am particularly grateful to him for giving us his time. May I thank also Melissa, who as ever has done all the arrangements for this and done them superbly well, even if she has to cope with me being a bit daft about the machine sometimes. So without more ado, I'm going to ask Lambros to talk to us, and then we have a number of questions that have been brought in, and we will run through those with Lambros and see what more we can learn. Lambros, the floor is yours.
Thank you very much. Thank you all for your presence, and Baroness and Melissa for, and of course Beata, who has invited me, and for communication and organizing this event. And it is a great honor to allow me to share with you the sickle cell disease and thalassemia, past, present, and future, which is really a very important and really fascinating disorders coming from mainly the Africa and the Asia origin. And we have lots of aspects to see with regards the past, present, and future. I would like to go on, but unfortunately my screen has been frozen, and it's the facts of the, yes. So those two disorders are the main representatives of hemoglobinopathies, who are a group of hereditary disorders of hemoglobin synthesis. And hemoglobin, to put you a bit in the hematological aspect, is the main protein inside the red blood cells that carries the oxygen that we all need in our cells for appropriate function. And the specific part of the hemoglobin, the globin chain, is where the sickle cell has a quality abnormality, and thalassemia that has a quantity abnormality, leading to the pathology and mainly the anemia that is affected. It is very important to say that those disorders, hemoglobinopathies, and specifically the sickle cell disease, as we see, are the most common single gene disorders in the entire world. And this is a structure to give you a bit of an idea. Here in the left, we can see the red blood cell that is like an amphicyal disc that inside contains this interesting structure. Is that is the hemoglobin, the whole structure that is containing 4 globin genes, as you see with the green, orange, and pink colors. And inside of its globin, we have the molecule of heme that contains the iron and carries the oxygen. In this slide, we see an interesting comparison of geography of sickle cell and thalassemia that gives us in the center, of course, Africa, that is highly affected in both disorders. But we can see in sickle cell disease that also parts of South Europe, Middle East, and Far East affected. Whereas in thalassemia, there is this characteristic zone and axis starting from southwest of Europe, going and terminating to Southeast Asia and Indonesia, apart from Africa, giving a huge territory of population that is affected by both alpha and beta thalassemia. And of course, in addition to the sickle cell and thalassemia, you can see the geographic distribution of malaria that is sharing certain areas, especially in Africa, South Europe, Middle East and Far East, and Indonesia. And we know that endemically, and that has been proven by large studies and statistics, that the population that is affected from malaria when they carry the sickle cell or thalassemia genes, they can have a bit better response to malaria, as especially in thalassemia, the parasites that are inserting the red cells, as we see in this picture here, and you see the red cells, and inside you see these small rings of the parasite of malaria, ending in taking all the nutrients and finally hemolyzing and destroy the red cells and multiply more, going to affect more red cells. Actually, in thalassemia, but also in sickle cell, they cannot acquire sufficient nutrients from the red cells on one hand, and also there are studies that the thalassemic red blood cells may have a greater affinity to anti-malaria antibodies. In that way, they are more protected against the disease. In sickle cell disease, more specifically, it is the most common monogenic disorder globally, and only the United States is affecting currently 100,000 people. We do not know exactly what is exactly the amount of people that are having the severe disorder. Could be at least 5 to 6 millions, but we know that even the carriers, so the people that are only having one gene being affected, are approaching the number of 30 million worldwide. In addition to that, there are many newborn kids born annually, about 300,000 currently every year, and that number, with the expansion of global population, could be reached even to 400,000 people by 2050. So you see, we're talking about a very common disorder, and it is estimated that 5% of global population most likely has at least the gene of sickle cell. And in this slide, we can see that nowadays, and that is a recent study in 2015, the newborn babies with sickle cell anemia are not only in areas of Africa, in actually every state of Africa has newborn kids with sickle cell, but all Middle East, India, and Southeast Asia, but also areas like North Europe, like UK, or North America, South America, even Australia, because of immigration now of population, do have a quite significant amount of and number of newborn kids that are born with sickle cell anemia, making that from African and Asian problem a worldwide problem. The inheritance of sickle cell disease is an autosomal recessive, so that means that it is not a powerful gene. It needs to express the disease, both the two alleles of the genes to be present. And we have, apart from the homozygosity of sickle cell genes that both genes are present and expressed, there could be a combination of a sickle cell gene with either a thalassemic or other hemoglobinopathy gene present. And of course, the carriers that are just having one gene affected are having, as we say, the trait. They are not expressing the disease, but as we will see later, they are very important to be screened from the point of risk of transferring that to their offspring. The sickle cell anemia is a product of just one change of a nucleotide in the huge strain of DNA, and that leads to the substitution of one single amino acid, as we see here, glucamic acid to valine in the hemoglobin product. As we see now, if two parents, each of them have the trait, so and the father has one gene affected and one normal, and mother has one gene affected and one normal, have 20% of chance to have a baby being affected with sickle cell anemia, and 50%, 2 out of 4 offsprings will have the trait. The importance of sickle cell changes is that the red cell that is in an amphicyl, very soft and easy to pass in the small vessels shape, in case of deoxygenation is polymerized and is transformed to this sickle cell that is not very flexible and actually can not pass through the small vessels. And in that case, we have thrombosis and ischemia of the small vessels. That can happen in actually every vessel of the body. And apart from the genetic, the genotype, the genetic background of those patients with hemoglobinopathies, there are certain other non-genetic modifiers of the phenotype, as we say, of the expression of the disease, including the weather, even the air quality, and that goes to the pollution that we have in large cities, even some habits like smoking or infections or poverty, and we can imagine how important factor is for Africa and Asian countries that can make the expression of the disorder much more significant. The complications, as we see here in the slide, can affect any part of the body, from brain to the tooth. And the general characteristic of those patients that have the severe phenotype is that they are experiencing chronic and recurrent veno-occlusive crisis, from which the most important and significant is the acute chest syndrome. For that, they require many times hospital admissions for treatment and many times they are complicated with infections, so they require antibiotics. They have a shrinked small spleen, and that is another reason for more sensitivity to infections. And they have, if they are not treated with modifying management in end organ damage, with damage of the brain, the heart, and kidneys. And unfortunately, the previous decades, we had early deaths, even from pre-adult age. Not also forgetting that the social stigma and the chronic painkiller use because of pain, such as opioids, are giving extra socio-psychological problems to the individuals. A picture here to show the disaster and the very catastrophic effect of the chronic ischemia in the femoral, the head of femur, which is characteristically seen in many patients, and is called avascular necrosis, and that requires physiotherapy and many times surgery. The ulcers that are painful many times in the lower legs from vein insufficiency and the problems in circulation are also very often. However, we have managed over the last decades to develop a very significant and effective treatment and supportive management for those patients. First, with antibiotic prophylaxis and, of course, treatment in case of infections. The vaccination program that is very effective, especially in pneumococcus and meningitis protection. And most important, the red cell and the red cell exchange transfusion, as we see here in the picture on the left, through the machine and the device that through usually a central line, we can exchange a whole volume of patient's blood. Imagine that in those patients we can exchange giving them around 8 to 10 units of blood and removing practically almost all their blood with a sickle cell away. So we give them normal red cells and we help them to compensate with the crisis and other complications of the disease. The trial medications that have been used and a previous medication of hydroxycarbamide or hydroxyurea is also very, very helpful in increasing the hemoglobin F and also to decrease the inflammation that those patients are characterized by. So we have as well as the prevention and early diagnosis now with prenatal, antenatal, and neonatal screening programs happening not only in developed countries and Middle East, but also the last decades in Asian and African countries has helped in a great degree of identifying potential sickle cell traits and prevent the number of newborn babies. And even in the a newborn baby potentially has sickle cell anemia, it can be easily identified and being started on treatment. And with all this prevention and supportive treatment, we have seen an amazing change of life expectancy and improvement from, unfortunately, a century ago that was even below the 5 years of age. Gradually, over the next decades, we managed to allow in the vast majority of patients to reach adult age, and towards the millennium to reach the middle age with the introduction of red cell exchanges and hydroxycarbamide. And nowadays we have in our department even patients in their 70s managed to become grandparents. So we will go through the future of the treatment of the sickle cell after speaking briefly about thalassemia, which comes from the Greek words thalassa, which is the sea, and emma, which is the blood, referring to the anemia of the sea, divided into alpha and beta thalassemia mainly. And there are also very increased numbers of patients, approximately 60,000 people with severe form of thalassemia on an annual diagnosis worldwide. Not as high as sickle cell, but still a quite significant number. Dr. Cooley described the disease in 1925, but thalassemia terminology was proposed by University of Rochester doctors. Again, we see this axis of southwest Europe to Indonesia, with mostly beta thalassemia affecting Mediterranean region and alpha thalassemia the far east. And to the genetics a bit, and as you see with hematology, we are involved with every field of medicine. It's very fascinating that we have managed not only to identify the genes that are connected to beta thalassemia that is situated in chromosome 11, and the pair of alpha genes that are on chromosome 16, and alpha thalassemia, which is referred to the alpha genes. We have total 4 genes, 2 on each chromosome. And when 1 or 2 genes, as we see here, are affected, there is not a problem, as the individual can compensate really well, and maybe a small, tiny degree of anemia could be presented, but not really giving significant problems. Whereas 3 or 4 genes are affected. In that case, serious problems can appear, and the absence of 3 genes cause the hemoglobin H disease, giving to the individual severe hemolytic anemia and splenomegaly. And unfortunately, babies with all 4 genes affected, they develop the so-called hydrops fetalis, severe cardiopulmonary disorder, and unfortunately they die even if they manage to be born soon after that time. In contrast, the beta thalassemia genetics share many common things with sickle cell, as there is 1 gene in each chromosome. So as with sickle cell, if we have our parents that are having 1 gene affected, so they just carry the beta thalassemia gene, and they may not experience any symptoms at all, and that is the very tricky condition that can give born to a child with moderate or severe anemia, and 2 out of 4 children with thalassemia trait. The phenotype of the thalassemias are either non-transfusion dependent, but in severe lack of either alpha, but mostly on beta thalassemia, and we call it beta thalassemia major. We have a great degree of anemia. The patient cannot survive without transfusions, and they are transfusion dependent, requiring every few weeks top-up transfusion. And of course, the severe anemia can give multiple complications to the patient, not only the degree of non-effective production that is not allowing the individual to develop appropriately, but also the fact that there is the red cells are destroyed more easily. We have the so-called hemolytic anemia, can give jaundice as symptoms, and gallstones to the patient because of high bilirubin, as well as changes in both bones because there is hyperproduction of red cells and there is a pressure inside the bones and the bones are transformed, but also other organs such as spleen and liver can take over the production of hemopoiesis and they can become bigger in size. The need of transfusion has not only developing the patient to become a bit more stable clinically from one side, but on the other hand, has led to iron overload because the blood contains iron. And iron is very important for all cells of the body, but in iron accumulation, as it happens with multiple blood transfusions, has severe defects in the heart, liver, and endocrine glands, leading to an organ damage. We see here the characteristic changes on a young kid with thalassemia in the in the bones of the face, as well as in the X-ray of the skull. We see this hair on end appearance because of hyper production and the hyperactivity of the bone marrow. Very also common finding is this changes in the bones, again from hyperproduction of hematopoietic tissue, is so-called extramedullary hemopoiesis. Many times they are presented like masses in the spine, in the ribs, or other sides of bones, causing even pains and problems to the individual. And despite all the complications of the anemia and the multi-organ failure that this can end up to, we have managed, even with severe cases of thalassemia, with red cell transfusions to start with, but also with treatment of moving the iron away of the body with a variety of medications, as well as with support of the endocrine damage with hormone replacement, osteoporosis treatment, as well as a close monitor of heart and liver, and splenectomy that can be performed in the patients that has been shown that has improved the outcome and presence of complications. We managed to improve not only the quality of life, but also to improve, as we see here, the life expectancy that was quite significantly impaired. And as we see in the up to the 70s, most patients would have died by the age of 24, whereas now the vast majority of patients can approach the age of 50, and especially with a good iron chelation and a good monitor, they can even live longer and with excellent quality without organ damage. Again, as with sickle cell, the prevention of thalassemia is very important, and with combined collaboration of medical personnel with the state, sometimes with communities such as religion organizations or non-governmental organizations, there is more education of people and more, especially in endemic areas, more knowledge about the disease. And it is very characteristically the example of Cyprus that even from 30 years ago, they have managed to eliminate almost to zero the newborn thalassemia major infant. Going to a very interesting and very positive now and towards the future of the the management of those real severe and complicated and even causing a fatal outcome in patients, especially the previous decades, we have developed a very promising and really supportive management of the sickle cell and thalassemia. And in the previous decades, we have developed and performed the allogenic bone marrow transplantation for individuals that could fulfill criteria from a compatible sibling donor. And in that case, the patients could completely change the red cell, of course, profile and manage to survive with a normal life. Of course, the bone marrow transplantation has lots of complications from infections, from the so-called graft versus host disease, and of course other complications, even from the first days up to late defects. So unfortunately, we can still see patients dying from that. The most promising, though, treatment is developing over the last years, which is gene therapy in both sickle cell and thalassemia patients that have severe profile. And in this treatment, we actually take an amount of the stem cells of the individual. We insert through a virus, usually now we use a lentivirus vector, a normal gene, either normal beta globin gene or a gene that actually will manage to promote the hemoglobin F. It's another hemoglobin that can help a normal production of red cells. We culture the cells, and then the cells are transplanted back to the patient. So his own cells that are just modified with the correction of the hemoglobin, of their hemoglobin, then are transferred back to the patient. They can multiply, giving very good results in improving the hemoglobin, have both good quality and quality of normal hemoglobin, and is especially the hemoglobin F promotion that has been published recently in the New England Journal of Medicine by two different teams has been shown very, very good results. And in the second team, we have to mention Professor Joshua De La Fuente, who is a consultant hematologist in the pediatric hematology department and bone marrow transplantation team at St. Mary's Hospital, participating in this study, showing very, very good and promising results. So, coming to an end, the prevention programs and improved newborn survival in sickle cell and thalassemia, even in low-income countries, but also in multi-ethnic cities, developed countries, has helped very, very significantly in the improvement of quality and the survival rate of the individuals suffering those disorders that previously were fatal, but currently we have managed to insert them in like a chronic disease, but with the allogenic stem cell transplantation and mostly with the gene therapy that is coming more and more with promising results, we're moving towards a cure of the disease. And we should mention two organizations, the Thalassaemia International Federation that gives very important information and guidelines for thalassemia. And for UK, it is the Sickle Cell Society that has done an amazing job publishing guidelines for the sickle cell care. And we have the example, the excellent example of UK again, of the National Hemoglobinopathy Register, that any, and actually all the sickle cell and thalassemia patients should be registered, so they have a database for all clinicians around UK, so we can have a close monitor, follow-up, and that way we can provide the best supportive care. And that is an example for how also the developing countries, with all, of course, the difficulties that we can discuss in Africa and Asia, could follow in order to improve the outcomes of both disorders. Thank you very much.
Thank you very much, Lambros. We've got loads of questions for you.
I'm
But
sure.
may I say, from my time in the early 60s at Great Ormond Street Hospital, we have come a very long way thanks to you and many of your colleagues. My golly, what a difference. Right, first question is from whom, Melissa? First questioner.
Unmute. Gloria's with us, I think, and she might be able to comment or ask a question.
Gloria, Baroness Hooper.
Thank you. And thank you also, Professor Bourantas, for such a brilliant presentation, making a very complex subject almost understandable for us lay people. My question is fairly basic. Have you observed an impact and an increase in these diseases as a result of the COVID pandemic?
It was, yes, thank you very much for the question and for your kind words. We have seen an impact in all fields, of course, of patients, but because we are looking after a great population of sickle cell patients, especially in the beginning of the pandemic, it was a real challenge for us to looking after, reassure that the patients stay well and safe. And our lead, Professor Mark Layton, who is one of the world experts in sickle cell disease, has scheduled a plan even for a home visits and patients to have pulse oximetry and have their medications at home. And of course, to have early admissions on patients that had symptoms, providing them with best treatment with red cell exchanges in complications. And we had the amazing, I think, result that has been published by our team, to have numerous patients, even more than 60, I believe, in our department and in our wards to be treated, and no death, fortunately, outcomes. That was really an amazing result. Of course, there are ongoing issues with the patients because the pandemic hasn't really ended, and we are towards, of course, the vaccination of patients towards COVID, and I think we have also succeeded really well. And of course, the continuous updates and education of patients how to be protected from the infection. But also in that field, despite the difficulties, we have done very, very good so far, and we are very positive that we can continue with very good results in the future.
Well, congratulations and thank you.
Thank you very much. And the next question, Melissa, is?
Rami, I think, is with us. Yes.
Rami? I can't see him at the moment, but he's there.
Thank you, Baroness. Professor Bourantas, we are grateful to you for your work. Your work is making the life for so many people worth living, and we owe you a debt of gratitude. My question is, I understand that thalassemia is very common in Greece.
Yes.
And is the people or the government of Greece or the people or private, are they doing any research how to, get rid of this problem? Is there any research being done in Greece?
Yes, there are many articles, and we can also, if you are interested, we can also discuss it further on through emails. And there are numerous publications, even from 70s, in both Greece and Cyprus about the thalassemia data in patients, the complications. The programs of management with the transfusions and iron chelation. And we have also in my hometown in Ioannina, in northwest of Greece, we have a department of thalassemia, treating patients with mostly beta thalassemia, but also a few patients with combined sickle cell and thalassemia, with very, very good and promising results. Of course, with unfortunately occasional deaths in middle-aged patients, but the overall the management has been well improved according also to the global guidelines, and especially in the field of heart, liver, and endocrine complications. There is also a very good response and improvement, preventing the end organ damage that actually can kill the patients, apart, of course, of infections. So overall, despite, of course, the financial problems over the last years, and the lack of doctors that unfortunately has been happening in my country, and we see even in large institutions in Athens that we are lacking doctors, I think there is a good experience, and with the research also of professors and senior doctors, we have managed to go with the standards of global guidelines.
Thank you very much, Lambros. Thank you, Lord Ranger.
Thank
And
you.
the next questioner, Melissa, is...
Yes, what we're going to do is we've still got about 10 people and a shortage of time. So we're going to have to be very quick with our questions and perhaps brief with answers, Lambros, with your permission, and we can always come back for a fuller response.
Yes.
So if we could do that, that would be a way of managing getting through people who are very keen to ask. So if we could call Peter Friedman, Bernard, Brian Weller, and Beata to ask your questions quickly, and then Pete Marshall, Chris Buckwell, William Knight, Ruth Barry, and Ilma, and finally Michaeline, Steve, Alistair, and Francis, and then that would be the end. So
If we don't get to the last group, we will do it by correspondence and email.
Yes.
But we'll try.
Happy to
Peter
contribute.
Freeman first, and then quickly followed by Bernard and Beata.
And Brian Weller.
Thank you. I retired from the city in 2007, and since then I've been actively teaching in schools in London, especially in areas where lots of children and teenagers are from Afro-Caribbean backgrounds. In all my time, I have never come across any mention of sickle cell disease. So I'm wondering what can be done, what can actively be done to raise awareness in British schools and amongst parents of the implications of the disease.
So now we'll go to Bernard.
How serious is this in sub-Saharan Africa? And how confident are you that we are going to be able to make an impact in remedying this awful disease?
Beata?
Thank you, Lambros, for the interesting talk. Is there any danger in giving the COVID vaccine to the recipients of both of the groups?
And Brian Weller.
Yes, it's okay. I'll pass my time until next time.
Oh, fine. Okay, great.
Lambros, could we have answers or guidance, please?
So shall I give a brief brief
Yes.
yes,
Yes.
and answer yes. For the first question, it's very important, yes, and it's really very, very interesting that you have pointed this issue, because unfortunately, and that happens to very many medical issues that are actually not very uncommon. We don't have an awareness of the general population about the existence and the problems of both sickle cell and thalassemia. And it is interesting in UK, especially around London. But imagine not only London, I was working previous years in Hertfordshire, and we have every year approximately 300 kids, even more, that are born with sickle cell anemia, the severe form of sickle cell anemia. There are more than 15,000 citizens living in the UK suffering from the disease. A bit less numbers are for thalassemia, but again, it is quite a significant population. And in that way, we should have more education, and maybe people like us, doctors, or people from societies of thalassemia and sickle cell, that could organize campaigns to schools, even like this, like a video link updates and quick presentations to update, especially to realize that there are young kids around us and young adults that are suffering from the disease. And it's very, very important nowadays, especially with the good management. You cannot realize them that you may be talking with the patient, with the person that is suffering sickle cell or thalassemia. The thalassemia now profile, even in bone deformities, has been dramatically improved, and sickle cell patients normally, especially with the good treatment, they don't suffer complications. So it is really important for people, especially at schools, for young teenagers, to be aware, and that is a very useful tool, and also for their lives, also for their attitude towards their friends or their schoolmates, or other people in their neighborhood or in their work, that may could suffer this condition, and is the basic tool for having a better behavior and being more civilized, is to be aware and have the knowledge of something. So that's very, very important to have campaigns, and we should promote the societies to go more and approach schools for that.
Lambros, I've
yes?
got a suggestion I'm going to make, and that is that we brief Robert Halfon, who is the chairman of the Select Committee in the House of Commons, about what is going on in the schools, and also prompt the GLC to look earlier, because it's not uncommon for lack of attainment to be revealed in some of the symptoms associated with this disease. Can we come to the next group, please, Melissa?
Sure. The next group is Pete Marshall, Chris Buckwell, William Knight, Ruth Barry, who is miles and miles away, even in Africa, I think, and Ilma.
Right.
Me first, is it? Right, okay. My question here is that thalassemia and sickle cell anemia are overrepresented in Africa under serious underlying health conditions that exacerbate COVID-19 infection to the extent that they will cause hospitalization and death. But so is COVID vaccine hesitancy particularly high there, due to misinformation and misconception spread by social media. Can you say anything about tackling that problem, Lambros?
Okay, and now Chris Buckwell, please. Thank you.
Thank you, Melissa. Lambros, I'm wondering whether you detect a significant difference in the incidence of sickle cell dependent upon the size of the country concerned, and in particular, do small states get sufficient general assistance to deal with the matter? Thank you.
Great. William?
Fine, William? No?
Good evening.
Oh.
My question is much more to do with the funding and governance of the African Development Bank rather than the questions on sickle cell. So perhaps this should be addressed through separate correspondence.
William, I'll talk to you about that at some stage in the future, if you would like.
Thank you.
Ilma?
Yes, thank you. Lambros, thank you very much for your talk today. And I have a very sort of general question. If a vaccination, any form of vaccination, can be helpful in the case which you were talking tonight.
Thank you very much. Yes, very nice.
Oh, and Ruth Barry as well. Sorry, Ruth Barry.
Dr. Bourantas, thank you very much. My question is more commercial. Considering the example of the companies involved with COVID and their response to Africa, and considering the cost-benefit risk of the companies involved in thalassemia and sickle cell, what do you anticipate the timeline for these treatments to be accessible to African countries as COVID is now? Thank you.
Thank you.
Lambros.
Thank you all for your questions. Yes, I'll try also to go to previous questions as well. Yes, with COVID-19 vaccination, there is, of course, an issue, and that has been also circulating in the media with the efficacy side effects of the vaccine. And of course, we have, as scientists, been seeing some complications of the COVID vaccine with thrombosis risk and other potential heart complications. However, the message is that especially with vulnerable populations such as sickle cell and thalassemia patients, they are highly recommended to go to COVID vaccination according to guidelines. And we have a good response that seeing that we have literally no new patients, touch wood, of sickle cell or thalassemia in our department being admitted with COVID-19 new diagnosis. For the last several months, actually, which is a fantastic result, and one way or another has, I presume that the message has been passed to patients and their environment that the vaccination is beneficial, and actually they have done really well. So I presume that the vaccination has been, despite all these, of course, discussions and this spread of different opinions, has been going forward. And the most important, one way or another, is that the sickle cell patients have been well protected, and they are not facing that complication. It is very safe for them to have any of the vaccines. Of course, with some precaution, I would personally advise for younger people to avoid the AstraZeneca if they could have another option. But also, we haven't seen any sickle cell or thalassemic patient having a complication from the vaccine so far. So we have very positive results from that field. Going to the question about small countries that like, for example, Cyprus or small African or Asian countries that we have data that they have significant populations of sickle cell and or thalassemia. They need, of course, support from other countries and non-governmental organizations in order to go through the basic prenatal and antenatal screening of the children, as well as for the supportive, at least, management, and also going further on to the question about how, if they can afford those countries, the cost of the management. I understand that, especially with sickle cell, that they may require recurrent admissions. They also the amount of blood that not only has to be given in a large proportion, but also has to be checked very efficiently for viruses and potential antibodies that can give further complication is a long, cost-effective process. I really appreciate that. And my impression is that, unfortunately, in those countries, with exception, of course, for example, Cyprus has been entering the Western, actually, it has been an EU member, so has reached the standards, but other countries unfortunately need more support from all political and economic agents in order to manage to compensate with that, as they can. My impression is that they can offer only the basics, and of course the centers, for example, for bone marrow transplant and even more for gene therapies is still a dream for them. But those talks and discussions, and of course the message that these conditions, how no matter how severe they are, they can be faced as long as we have a schedule in advance. We can support, and with the experience that we have developed all over the years with research and the new technique and management, can be passed, and we can give this message of the positive outcome, with, of course, all the difficulties that we face.
Lambros, thank you very much indeed, and to all of you. It's 18:59 according to my clock. I must thank you, not just, as Gloria said earlier, for all the work that you're doing, the research that you've done, but your willingness to come and talk to us, a non-medical group, some people obviously with medical experience, and it has been illuminating. And I will use what you've said tonight very much in my work for a Ghanaian organization called AfriKids, because quite a lot of our kids, sadly, have exactly the problems you have described. Can I thank all the questioners who managed to get in? I don't know when a non-Foreign Office subject per se has generated so much interest. It's a very good idea that we expand, but not in 1 hour. We need to have longer meetings, otherwise we'll never get through it all, and I shall be in trouble with the organizer.